on this episode of med-surg Moments.
What does nurse-sensitive quality indicators mean to you guys?
What's the podcast equivalent of a blank stare? This is Eric,
Maritess,
Sydney,
Sam,
Neo,
and Laura. Welcome to med-surg Moments, the AMSN podcast. This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
we're proud med-surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Our topic today is nurse-sensitive quality indicators. But as always, before we get started, we're going to do some personal updates, maybe some roses and some thorns. Sydney, why don't you go ahead and get us started?
Thanks, Sam. For a rose this week, I would say I have a really big trip coming up that I'm excited about. My boyfriend is coming out to visit, and we're going to Amsterdam to see the tulips, which has been a lifelong dream of mine, especially top bucket list for being in Europe. So I'm really, really excited. We got tickets to the Keukenhof Gardens. I think that's how you say it, but I don't speak Dutch. So we're really excited for that, and we're going to do some sightseeing. So that's going to be really interesting. Thorns-wise, at work, I just feel like my cup overfloweth with things to do. I talked about in the previous episode, my unit went through a merge between the labor and delivery side and the med-surg side. And on top of our nurses doing cross-training, we have corpsmen. And so what corpsmen do in the military, at the Navy specifically, they're most similar role to a LPN. They can do assessments and pass meds, but a lot of them come straight to our hospital from school. It's like a new graduate nurse. That's not as long as a BSN. So we have an orientation period for them. But since we've merged, our orientation for the corpsmen hasn't been merged. So we had a separate labor and delivery training and a separate med-surg training that we've been kind of just meshing together. So we're in the process right now of creating a combined orientation so that they can just show up and learn everything. So that's been a big collateral duty that I've been working on with our department head and some of our leadership on my unit, which is taking up a lot of time on top of working bedside. So I'm really excited for this trip to get a break. Maritess, how about you? What are your roses and thorns this week?
Sydney, I want to say kudos to you for stepping up and doing that leadership role, because it's huge. Just like what you said, you're doing a lot of work already in the med-surg unit and also doing this. But most especially, I'm very excited and happy that you're making that trip. I wish I can get my PTO again. Part of my thorn is really we're reflecting on our trip. And I wasn't sure if I shared this previously. One of the reasons why we went to Japan was because my aunt actually passed away while she was on a trip to Japan. I was pregnant at that time when she passed, and so I didn't get the chance to come and visit in the Philippines. So that was very emotional for the family. Looking back, putting together our pictures for our scrapbook kind of made me really realize life is very unpredictable, and you really just have to cherish every moment. Be in the moment all the time. Be present with everyone. If you think of something, do it now, or the moment will pass. Well, roses, recently I got appointed to be board member of the Global Nursing Accreditation.
That's awesome, Maritess. Congratulations.
Congrats.
Thank you. No, I'm very excited. Thank you. The reason why I had to consent to serve for that is because as an internationally educated nurse, that's the main purpose. We wanted to really ensure that there's competency and qualifications are set for internationally educated nurses, but also we have to be very transparent with recruitment and making sure that the nurses who come to the United States are at par with the standards that we have here. And so I know there's a lot of work, but very, very excited. The members are not just in the United States, it's worldwide. So there's going to be really a huge impact. Eric, what's new with you?
So first of all, drum roll please. I finally got my cast off. Patient fell, broke my ankle, tore my Achilles tendon, broke my toes. 10 weeks up with this foot all bandaged up. I've never had anything broken or had surgery. I got this cast off and I look like a human croissant. I could never imagine the layers of skin that would just be trailing and sticking. Having a nurse brain, I couldn't stop taking pictures and sending it to everybody because it was so disgusting.
So I'm sure they all appreciated it.
Yeah. Yeah. All my sisters just couldn't look at it. But I thought, man, so it's a little more freedom. I'm just in a cam boot. I still can't walk, still have to keep it up, but baby steps. So I'm excited about that. I start therapy soon, and they said maybe another 4 months before I can get back to work. So we'll see what happens. It's just a big old briar patch of thorns with flowers, But it's given me more time just to research and more time to do things that I never knew I wanted to do. And what about you, Neil? What's going on new with you?
Roses and thorns. So I'm recovering from my fantabulous 50 voyage of life, back at work, and I am off the orthopedic floor I was a charge nurse for, which I kind of miss being a leader, but I thoroughly enjoy being bedside and being the grunt again on this med-surg floor, ironically. School is that thorny rose that you're glad to be in it, but the struggle of getting work done. This is a test bank writing question kind of class, and that's my last physical class. And then after that's my 2 practicums. So then it's like student teaching, for lack of a better way of putting it. So I'm stressing that paperwork and trying to finish tying up the end of getting my licensure, redoing my certification and my ACLS. Laura, what's going on with you?
Oh, Neil, you've been busy.
Yes.
For me, things are going well. Work is kind of just trucking along. Not a whole lot to report there. But in my personal life, my husband has actually decided to take a little sabbatical from work. So he's going to be home for a couple of months. Not quite sure how that's going to go. That could be a rose or that could be a thorn. We'll see. I will keep you guys posted. Outside of that, I do have a girls' trip planned next month, I believe. We're going on a cruise. So I'm extremely excited about that. But other than that, life is just moving forward. Sam, what's going on with you?
I wanted to comment real quick back to Neil's practicum paperwork. I recall that being probably the worst experience of my entire MSN program.
I want to cry at times.
It is insane, especially because I don't know if this is what you were doing, but I was doing my practicum at the place that I worked, basically in my job.
No,
and I had to do that. This is going to
get
be
stuff
like
signed.
Oh, yeah. This is going to blow your mind, too. I had to ask employee health for my vaccine records, upload them to my university thing. They sent them back to my employer as my potential practicum site to approve me as a student. And I was like, if I can work here, can't I just skip all that?
I'm trying to make it easy, and yet I still have to do this. It's like, come on, can't there be an easier way?
Right. Yeah. I was not a happy camper about all that. And then my favorite thing too is I was already working in a nursing education position. So doing this practicum, I didn't really learn anything different necessarily. I did my practicum with a coworker. It was finishing up. It was the home stretch and it was fine, but I will forever have a little bit of a grudge on that whole process. So I feel for you right now. I think just rip the Band-Aid off, get it done as soon as you can, just so it doesn't delay you at all would be my suggestion.
It feels like ripping off a why can't I think of the name of the bandage?
Like a Tegaderm or something?
Yes, it feels like more like ripping a Tegaderm off than a Band-Aid because it's just muddling through yes, the challenges you face. You're I kind of miss my ADN program where they took care of most everything. Yeah. Uh-huh. Rip the Tegaderm off is definitely the feeling.
Yeah. I think we've all done that to our poor patients. Sorry, free wax while you were here that you didn't sign up for. That's what I would tell them anyway. So, like I've mentioned the last few episodes, pregnant, first time mom, my husband and I having our first kid. So by the time you guys are actually hearing this episode, baby boy should already be here. So that is super exciting. You guys will probably be without me for a couple episodes, and then I'll hope to come back, see what everybody's been up to, and share parenthood situations instead of just complaining about being pregnant for 800 years is what it feels like. So really excited about that. Thorns. Let's see here. I think a thorn I would say at work right now is just this ongoing work. We implemented a new piece of technology in December, and I was the clinical lead for it, a new IV pump. And there's just been some kind of longer drawn out issues. And I would say that those have been a bit of a thorn for me. But overall, the thing went well, but still just trying to work through and navigate some of those things so that hopefully we can just kind of keep on trucking along and then get ready to integrate our new pumps with our electronic health record later in the year. So more to come on that, probably Q3, Q4 of this year. So but I think that's about it for me. So why don't we go ahead and get going on our topic. So like I mentioned, our topic today is on nurse-sensitive quality indicators. And to get us started, I thought I would share kind of why I wanted to talk about this topic. I am a nurse educator, NPD practitioner, and so a lot of that role for me right now is doing a lot of check-ins with nurse residents or even experienced nurses who are new to the organization. And we kind of have this standardized form that we like to use so we can kind of track the progression of their onboarding and things like that. And one of the questions that we always like to talk about are nurse-sensitive quality indicators. So before we kind of dive into discussing this topic, I actually wanted to ask and see if Sydney or Eric are bedside heroes here on the podcast. What does nurse-sensitive quality indicators mean to you guys?
What's the podcast equivalent of a blank stare?
Sydney, any stab at it?
Well, if I'm not looking at my 2 pages of notes that I took before this episode, because I didn't know what it was, but I wanted to be prepared, it would have been a blank stare also.
I love the honesty, truly. So what did your research tell you, Sydney?
So from what I learned from Dr. Google, was that nurse-sensitive indicators are specific patient outcomes that are influenced by nursing care. And these measures are used to monitor the quality of care and patient safety at hospitals.
That hits the nail on the head.
I always think of it as preventable conditions. That nurses doing proper nursing actions can actually prevent these conditions from happening. That's how I always think of it in my head.
I like to think of it as the why we do what we do. Kudos, Samantha, doing the onboarding education aspect of nursing. And that's what I kind of teeter with sometimes because I like the academia part of college. I think so many times, even with your CNA class, you don't get as much as behind the why we do what we do. Even as you get through nursing school, you come into the hospital, the infamous nursing school line of go by the procedures of your hospital, or go by the lab values, or whatever rule we're teaching. The why behind it is that indicator, because that hospital got kind of dinged for it or something happened. And so I think the human nature of everybody is what's the why behind it. And so I always kind of think of these indicators as the why behind what we do.
Mm-hmm. Yeah, I think that's a great point. I think what we see a lot at our organizations, especially with our new grad nurses, is being extremely tasky, right? They're thinking about all the things that they need to get done in their shift. What do I have ordered? What is the patient asking for? What meds are due, etc. And so it can get really easy to kind of miss the bigger picture and think of all of the things that go into preventing these kinds of things. So I do want to give some examples of some nurse-sensitive quality indicators. For my med-surg brain personally, and the ones that we hit on the most are hospital-acquired pressure injuries, central line-associated bloodstream infections, catheter-associated urinary tract infections, and falls, and even more specifically, falls with injury. So those are kind of the big 4 that we like to hit on.
Those are definitely continuous topics that we talk about.
Yeah, and that's the same with us. We do have actually a dashboard that I personally would look into every 2 to 3 days just to make sure that we're on track. And every time that we do have nurses who is having a struggle with work, one of the things that I looked at is how are they doing with indicators? Because I see these nursing sensitive indicators as the outcomes of what we do as nurses, even though no one's watching. It used to be like no one is really looking at all these numbers. And now we're really focusing on that. Then we want to process improvements. But if nurses are doing what they're doing, even though no one's watching, everything's going to be great. We sometimes do a lot of workarounds. I hate to say that out loud because we have a lot of things going on. There's a lot of workload. And so maybe this would work, this would not work. Maybe I can do this, but it would really reflect the outcome. So if we do the work, even though no one's watching, no one's measuring it, the outcomes will be great.
Yeah, absolutely. I think you really were hitting the nail on the head there with the integrity component of doing the right thing, even though not everybody's going to know, or you're not always going to get the gold star for doing all the different things that we need to do to help prevent these things. So I'm going to put Eric and Sydney back on the spot again. So now that I've given those couple of examples, do you feel like that kind of clicked anything for you guys? Or is that something like you guys talk about in your departments or any other places that you've worked before?
Yeah, absolutely. I think I just didn't realize that there was a database and that there was an acronym for the things that just seem like nursing care. My last facility, I was part of our falls prevention team. So we did audits. We went around the units and is there a fall sign on the door? Is the patient wearing a fall band? Do they have a bed alarm on? And then we would do chart audits as well to make sure that the nurses are documenting that they did those things.
We start every shift with the same four that you guys are talking about. The HAPU, the CLAPC, the falls. I just didn't know it had a term, like an umbrella term, like what was the word. But then again, I'm like, hey, go give me that thing, the small thing that goes in the little thing here. And, like, do you mean this? No. So sometimes we just don't know the name. I've got much to say on this topic.
Well, let's hear it. What do you got to say?
Well, okay, so I was listening to Maritess and talking about integrity, and I'm all for it. I mean, like, yeah, in a perfect world, of course, we don't want anyone to fall or get a pressure injury or stuff like that. But I mean, it's not that I don't want that to happen, but sometimes it happens. I'm not a task-oriented nurse. I mean, you know what I mean? Because you can't. I precept a lot. I do the new hires. So I always say these are the tasks, but you got to look at the big picture. But realistically, I'm off of work because someone fell, because we didn't have someone there. I got injured last time because someone fell and I caught them. And I said, well, next time they're going to fall because I'm not going to get hurt again. And then someone fell and I'm here with a broken ankle. It's not just doing what's right. It's how do you do what's right with the time allotted to take care of
the resources.
Exactly. I mean, so I don't think it's as simple as someone was saying, oh, well, just be an honest person and do what's right when no one's watching, because that's not as simple as it is, because I always act like no one's watching. And, when things happen.
Yeah, and some things can't be prevented. No, even if you do everything right, some things can't be prevented.
Absolutely. And none of my patients are going to fall if they don't ask for anything. And if they don't need anything, you know what I mean? If I don't have to go pull a med, then no one's going to fall. But sometimes I got to leave, and sometimes someone wants a drink, and sometimes you can't find help. And that's just the way it is on the floor, at least. I would love to hear how some of these things are prevented, or how we can balance and how we can come to some happy medium. Because I have this discussion with my manager. I'm on a couple committees and I'm on fall committees, and there's no magic answer for it.
Does not surprise me at all based on what I've learned about you, that you are on multiple committees on top of working, on top of being on a podcast.
I'm committed.
On top of the couch.
I love that.
Yeah.
No, I think, Eric, you're making really great points that there's a lot of reality that goes into this stuff too. And I think a lot of our listeners will feel the same way, that sometimes there's just not enough minutes in the day to do all of the things. We know that there's different ratios across different med-surg areas, whether you're in the hospital or outside of that, things like that. So there's not a perfect answer for any of it, I don't think. But one of the things I did want to talk about too was being aware of your organization's bundles usually is what is involved with these things. So like I said, there's not like some magic sauce that's going to prevent your patients from falling or prevent them from getting happy. There's not one magical intervention, as nice as that would be. And so I think being aware of what is expected of you, or like what are the tools that you have when you're caring for your patients to be able to protect them and keep them safe and hopefully prevent harm as best we can. So like talking about hospital-acquired pressure injuries, for example. My organization has a leave-ins. I think Mepilex, is that the other one? The other big brand name? Yeah. So So some of those different padding devices, waffle cushions, the heel protectors, assessing their nutrition status. Do we need to get dietary involved, moisture management? Like there's a million different things. And so I think the best we can really do too is think about where is my patient struggling in this area and how can I really target my interventions to them? And that's a conversation I have with a lot of the nurse residents too. Like if you have a patient who is not eating and they're incontinent all the time, only turning them every 2 hours is not really going to do you many favors. So trying to kind of get over that hump and critically think through some of those components can be really impactful, and you're going to get more bang for your buck out of what you are actually trying to do to help prevent them from getting something like a happy.
I always say, I have to put this bed alarm on. I know you're only like 35, 40 and you're here just for something small, but I'm not going to have an accident. Nobody plans an accident, hence they're called accidents, And it's like you just reinforce that and you feel like you're talking to a kid sometimes, but they don't realize the brevity of that event on the whole floor, let alone the whole hospital and all the extra stuff that goes into it. It's amazing how the simplest things can cause the biggest mental headaches.
I really appreciated Eric's honesty with what you see there at the bedside, because it's so true. That's the most common comment of the nurses. They're like, I don't have enough time to do all these tasks. How do you want me to finish all these? And then when I say, well, you did try bundling your care, I'm like, I did bundling of care already. But I don't know what I'm talking about. And I'm like, I understand. Okay, let's see. Did you use this and that? And I appreciate you when you said, Samantha, about the resources, because I go back to those. Did you use the tools? Do you have the right protocols, the bundles? And they would say, we did everything that we can, but it just happened. And so there must be something else out there as well. And that's why we need to do continuous research. And I really wanted to find out personally, because falls, CAUTI, and CLABSI, we have all the best practices out there, but we still get CAUTI and CLABSI at some point. And so sometimes it's not even the practice maybe. So look into other gaps. It could be the process. It could be the system itself. Just recently, we found out there's nothing wrong with the bundle, nothing wrong with the protocol, but they changed something in the lab process that kind of changed the parameters. And we were like, this is the reason why the numbers spiked up. Sometimes we just focus on the numbers itself without really focusing on the other components. And so being able to speak up and say, we did everything. I like when you said, Eric, we did everything, but still the patient fell. There could be other factors that could have been involved in between that perhaps is not beyond our control, or probably something that we need to explore and research on. And I always say this, manpower is number one. We can put all the alarms, cameras, but if there's no one there who would be ready 24/7 for that patient, that's really high risk for fall. Or let's say pressure injury, for that person to really look every 2 to 3 hours, because that's how fast a wound can happen. But other than that, there could be other processes that we can improve on. Research, being able to really speak up. Don't be afraid to speak up if something is not working right in your unit.
Yeah, I think this is definitely a space where innovation and brand new ideas are totally welcomed and encouraged within your unit or your organization. If you've got a great idea that you want to try, like turn teams or something like that, definitely try to escalate that and get it up and give it a go.
Yeah, but also participate in debriefing when you have a CAUTI, when you have a CLABSI. When you dig down and try to figure out exactly what happened. What were the circumstances that surrounded it? I always told my staff when I was a manager that I don't expect us to prevent everything, but I want you to be able to say that you did everything that you could. And then let's look at it and see, is there something else that we could do outside of our current process? Like you said, Maritess, we need people to speak up, to come in and say, maybe there's something we can tweak. Maybe we need to look at our process in a different way.
It is a good idea to speak up, but then on the flip side, you need someone that's going to listen to you when you speak, instead of nodding and just saying, oh, okay, I hear you, and blowing you off. Sometimes the simplest answer is the best one. And I've seen it where people say, hey, this would help so much. And their manager's like, oh, that's a great idea. Let's never do that. And sometimes it's this fine line of being able to take someone's advice and not take offense to it. I've seen that far too many times where someone says, no, I'm the boss, I'm the manager, I know what's right. Sometimes I get worked up about this because I feel like a lot of people want to put the blame on the nurse. Like, well, that patient wouldn't have an injury if you turned them every 2 hours. That patient wouldn't fall if you rounded every 60 minutes. But that's not real life.
No.
Like how many times have I had to call a doctor's office trying to get orders released because after surgery, they're frozen. You can't do a single thing. You're tracking down the doctor for an hour and a half. So we had these really big issues with falls and with eclampsies, and we've been trying to work on it. So they initiated hourly rounding where you had to go to the rooms and sign it. And then for the happies, it's such a funny term, happy, because I keep trying to say the happy.
It is a funny term.
24. Yeah, it's a happy. So we do 8-hour shifts over here. The charge nurse and the nurse would have to go look at every single patient who had a rating less than 18. And it's just like, okay, so here's another 99 tasks that you're trying to fit in.
It's checking boxes. Yeah. It's not really fixing the problem.
And I've been a nurse for a bit, not a long time, but I mean, even just the short years that I've been there, I've always liked that leadership role. And I've always wanted to be the one to take someone to my wing and say like, oh, this is how we do it. This is what you're looking for. This is how you develop your nurse sense. But now it's like, this is the task. Here you go. Get started. 1 through 200. Get it all done and chart. And it's difficult. I wish I had the answer. I wish we could solve all this, but it's a multi approach. It's the patient also. It's their family. It's the staff. It's the managers. It's the doctors. It's everybody. It just gets me worked up because I do feel like it gets put on the nurses.
100% agree with you. It's all those tasks. And then it goes back to who was the primary nurse again?
Yes.
But the truth is, it's not really just the nurse who actually did all the tasks. I mean, this nurse was the primary nurse, but
Baited.
The manager's got her.
Silence her.
Silence her.
Is it Maritess or is it AI?
Yeah.
That's a hard one to call.
I think, it was the AI. No.
Mara AI tests.
I wanted to say, as far as educating your support staff as to, I think it was Neil that said the why, because they especially get very task oriented, and educating them on, well, why do we need to get them to the chair for every meal? At my facility, we don't always get older patients, but we had one recently and he's in the chair with all of his blankets on. And I asked one of my support staff to get him back to bed because he was like falling asleep in the chair. And I see her from the doorway and she's like, all right, let's get up. And he's kind of looking at her like, all his blankets are so heavy. I'm like, hey, you have to help him. And those little things that seem so obvious in your nurse brain, like, oh, I'm going to take these blankets off and then put my hand under his arm. We're going to count to 3 to stand up, but I'm going to make sure he has his grippy socks on. And those little things that prevent falls that are in our nurse brain already that your support staff might not know. It's like, all right, he needs to go from the chair to the bed. Or why are we getting him up for every meal? Or why are we checking if his briefs are wet every time we go in? Even if he says that he knows, I don't think he does. Educating your support staff on the why can help hopefully alleviate some of that nurse stress. Trust but verify, but also it helps them to be educated on what they're doing too. I think it helps, at least for my support staff are usually on the younger side, and it gives them sort of that purpose versus feeling like they're just doing tasks.
Yeah, I think that is such a great way to build partnerships with those support staff members too. And those ongoing relationships will usually be better if you're open to taking a few moments to share that time with them. I think it's generally very appreciated.
I do have a question about the nurse sensitive indicators and the database. If we have
ND&QI?
Yeah. How is that tracked?
Sydney's question is about ND&QI, which is the National Database for Nursing Quality Indicators. So if you work at a magnet organization, this might be something that you've heard of before. Where I work at a magnet organization, and we have to submit our data every quarter to ND&QI so that they can add it to their database. So on my team, actually, we have a magnet data analyst, and that is her entire job, is to help collect all that data, ensure its accuracy, and then send it into ND&QI.
So there's a lot of that chart review, or I know that's not your position. You said that's a whole person's job, but is a lot of it just chart review, or?
I think there's partnerships with our quality department. It's a lot of nurses. They kind of glean things through our reporting system. If a fall happens, then we submit into this program the details around it, and then they do a deep dive on their end. And they look at the charting, and they look at the circumstances of the fall and what interventions were in place, et cetera, and things like that. What's interesting about something like Indian QI is they have specific parameters of what counts as a fall, what doesn't. Like they have a definition of unplanned descent to the floor. So if we can prove that it was a planned descent to the floor, then we don't have to count it as a fall. So anyway, that's just
collected a lot of
things.
Yeah. For a little while, I collected this data for the unit that I worked on. I started with chart reviews. I started looking at documentation. And then I would go to the nurses that had either missed documentation or had an event happen. So we got their story, their side of the story. And like Sam said, there's different ways to look at some of that information before you submit it. So we did that as a committee, and it was in conjunction with our quality committee.
I think that's another podcast episode, like a value-based healthcare, because that's kind of like the continuation of that, I guess.
Yeah, because if things aren't documented in the right spot, then they can ding you as well. So there's education on that piece.
Unplanned descension to the floor.
Unplanned descent to the ground. Yeah,
I think that's one of my new favorite terms I've ever heard.
Dissension.
Yeah.
I think you made up dissension. I think I said descent, but
You did.
Either way.
But yes, either way. This has been such a great discussion, such a great topic to talk about with a mix of bedside folks and education folks and, this great group of co-hosts that we have going on for the AMSN podcast right now. So we are just about out of time. But before I recap, I do want to add one thing. And it is that I have had patients fall on my watch. I don't ever want this to sound like that I was a perfect nurse and I did all these things right. I think the educators here too, our listeners will also probably echo this, that we get to spend a lot of time reflecting on our own practice from when we were bedside. And I definitely did cut some corners and probably didn't do everything the way that I should have. But I just did want to put it out there. These things have happened to me and I took them as learning experiences. And now I do my best to share them, especially with those nurse residents or other new folks who are new to our organization. So hopefully that they can learn from my mistakes and not make the same ones. So
yeah, we can say that a lot about taking shortcuts. Nurses do take shortcuts. We've got a million things to do in any given shift, and shortcuts will happen. So what I always tell my new nurses, I'm not going to tell you I was perfect. I absolutely took shortcuts, especially when I was a brand new nurse. But the more you learn, the more you see, like Neil said, you got to understand why these things are in place, then you're less likely to take those shortcuts.
Amen to that.
Just tell people don't get sick. That's the best thing I found out. Just make sure no one goes to the hospital. Tell everyone to stay healthy, and we won't have these issues.
I'm going to send the insurance companies and make them looking for us.
Just tell them not to fall.
Yeah.
Yeah. They always listen. All right, so let's do a quick little recap. So, nurse-sensitive quality indicators are specific outcomes influenced by nursing care, which is why it's tied to quality. So, some examples of those would be hospital-acquired pressure injuries or falls with injury. Many organizations will use audits or dashboards that can track and measure these indicators. So, if that's not something you've heard of or seen before at your organization, I would definitely ask those questions of your department leadership. There are no magical interventions, but rather having the right tools in place may give us the best fighting chance in preventing these accidents. Nobody plans an accident, but anticipating and preparing for them can prevent the ripple effect on the floor created by these patient accidents. Many units and hospitals will have special bundles to help nurses in these areas, which include protocols and practices to help prevent these stress-sensitive quality indicators from happening. And nothing is perfect, so don't be afraid to speak up if something is not working right in your unit. There might be some opportunities to tweak your current processes, and if you feel like you're not being heard, then just keep going up that chain of command. To our listeners, thanks for joining us, and we will see you next time.
We look forward to connecting with you on the next episode of med-surg Moments, the AMSN podcast.
In the meantime, we encourage you to subscribe to med-surg Moments wherever you listen to podcasts.
To reach us, use hashtag med-surg moments on your social posts.
Or send us an email at amsnpod@amsn.org. That's amsnpod@amsn.org.
We're all AMSN members, and if you love med-surg moments, we invite you to become a member of AMSN. You can learn more at www.amsn.org.
Finally, the content within the med-surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, this is Eric.
Laura.
Maritess.
Neil.
Sam?
And Sydney. And always remember, med-surg Moments is a moment in our lives and a moment in our med-surg careers that makes a huge difference.